very much for inviting me, and it has been an amazing conference so far. Francesca, thank you very much for organizing such an amazing forum. I learned a lot. And I will be talking about our molecule, which is Ganaxolone, and Joe Sullivan will be summarizing what we have seen so far with the study, which to me seems that it's a long learning process that we are still in the middle of, so we'll have to think carefully about how do we go about this disease. So this is Ganaxolone. It's you can see from the slide here that the difference between allopregnanolone and Ganaxolone is just this one methyl group. And this methyl group has been put there with the intention of preventing allopregnanolone to go back to progesterone and going back to the steroid metabolism. So this drug was part of what was called at the time rational design. So they were trying to mimic what allopregnanolone does in the body without going with the side effects potentially associated with chronic administration of a drug that has steroidal activity. What we have seen so far in terms of efficacy, in terms of the way the drug works in various preclinical models, the two molecules behave very similarly. I mean, we recently have done some status epilepticus models that the previous speaker spoke about, and we have been able to replicate the efficacy story about Ganaxolone versus allopregnanolone. So again, it does not convert, and it works both at the extrasynaptic and synaptic GABA receptors, and I'm sure you have seen better pictures, but this is the one that we use in our presentation, the synapse and the extrasynaptic GABA receptor, and the affinity of the drug for both the synaptic and the extrasynaptic activity. So far, the drug, as you know, allopregnanolone cannot be administered orally, and our molecule can. And it took our company over 10 years and 13 different formulations to get to the point where we have an orally available drug. Part of the problem with neurosteroids is that they are very lipophilic. And what makes them good for the brain and easily available in the brain makes them very difficult into getting to the brain, getting through the gut. So that's why this company, our company, spent quite a bit of time working on formulating the drug to a drug that can be administered orally. After, as I said, after many formulations, currently we do have an orally available drug, and we have been developing it for adult partial onset seizures as well as some pediatric epilepsies. And because of the excitement about the potential link between PCDH19 and neurosteroids, that's how we ended up starting the study in using Ganaxolone in PCDH19. This is where we are. So again, we do have a phase 3 study in adults with partial onset seizures. This is the most advanced indication for us, and we do have a pediatric plan that we intend to have the drug available for children, whether it's going to be PCDH19 specific or not. The data will guide us. But so far, we do have an active phase 3 program in adult patients. We do have the study that we'll talk about more today, and we have an IV formulation that's very similar to the allopregnanolone formulation that we will be putting in the clinic later in the first half of 2016. We do have the study in Fragile X. The study is still ongoing, so I'm not going to share any data because I don't have any data. Unlike the PCDH19, the Fragile X study is blinded, so we don't know still the treatment codes for the patients. So this is the drug characteristic. I don't know how relevant it is for the patients and the family. For those who are involved in the study, we have suspension for children and we have capsules for adults. We still have a fat difference between 2 and 3 times. That's why we require the drug to be taken with food. We have a 72 hours half-life, It's pretty benign in terms of enzyme induction and behavior in the body. So far, we have not seen any inhibition or induction. We did have seen some decrease in the level of ganaxolone when administered with enzyme inducers. So far, we have not been able to trace that back to loss of efficacy, but again, we are doing a large phase 3 study that will inform us. We have been in children for a long time, and we have a pretty large pediatric database. The one thing we know from our previous exposure is that we do have an anti-epileptic drug, and we do have a drug that's safe. Outside of the sedation, that's pretty common with the GABAergic drug. We have not really seen any alarming signals. And we have been talking to the FDA many times. We have been started many programs. In the past, we have been in children as young as 4 months. And so far, the FDA is pretty well receptive for our drug. They don't put a lot of pressure on us in terms of, they don't have concerns in administering ganaxolone to small children. So in a way, that's the one advantage that we see, that we have an anti-epileptic that worked in very severe one open label study that was done in the 90s. And we did have a study that looked at West syndrome here the drug couldn't separate from placebo. So what we have been dosing the drug, so in terms of where is the drug active, what is the dose range that you can talk about, it's, we have been giving it at 36 milligrams a kilogram a day for the first study, up to 36 milligrams a kilogram a day with the West syndrome, and we went up to 54 milligrams a kilogram a day in the other study, and so far, we know, even from our current experience, that probably around 50 to 60 milligrams a kilogram a day will be the top dose, because if you go above that dose, children become sedated. In terms of side effects outside of sedation that I already mentioned, we did see some agitation, which is common with the GABAergic drugs that are available on the market. We have seen some rashes that have been mild and reversible when we discontinued the drug, and that was pretty much all we have seen in terms of safety. We have not seen any liver enzyme induction. We have not seen any QTc signals. We have not seen much of any other safety signal. So again, we have a relatively large pediatric database. We have almost 200 children exposed to ganaxolone, and this is a summary of what we have been reporting so far and the results. We do have more than 1,000 patients exposed to the drug as adults. So again, we have a relatively large safety database, and we know that the drug is efficacious and safe. Of the 200 patients that we have exposed, 135 are pediatric patients with epilepsies. Many of them had various syndromes. Some of them had a large percent of them had retardation. Many of them came with severe malformations, and still the drug was efficacious and was able to reduce their seizures. I'm not going to talk about PCDH19 and why ganaxolone. I think we have been talking and this has been addressed by people who know way more than I will ever do about PCDH19. But some of the people who are present here have been involved heavily in the design of the study. And again, the way we thought about this study was more about mimicking the clinical practice. So in other terms, if you are to treat a patient with PCDH19, you will have the opportunity to use ganaxolone, and use ganaxolone in a manner very close to what normally people do in their clinical practice. Joe Sullivan, who is the next speaker, he'll talk more about where we are. The study is still ongoing, and we are still collecting data as we speak. So what we share today might be different 2 months from now. So this is the study we had. This was an open label study, so that's why we can share some preliminary clinical results. And we started with the age group of 2 to 10, but once you have an age group of 2 to 10, there is always somebody who is 11 or 12 or 13. So eventually we spoke and we talked and we decided to extend the age range that we were allowing patients to be entered. So now it's up to 18. And I will not talk much about the study because the next speaker will talk. I'll probably spend some 10 minutes or so, if even less, talking about our IV formulation. The IV formulation was developed recently. It has been something that, because of the size of the company, we are a very small company, it has not been prioritized, but now we have it almost ready. We have done the preclinical tox package. And we have done some preclinical efficacy studies in pilocarpine-induced status epilepticus. And we were able to show that ganaxolone is active. And we do have plans to start the study in healthy volunteers, exploring the PK. What we will learn from the IV formulation will be the bioavailability for our oral formulation, because currently we don't know. And we do expect that the IV formulation probably will have a lower dose than what we have in our oral. So this was my presentation, and if you have any questions, I'm happy to answer them.
Thank you. Thank you very much.